Hi everyone, in this episode of CardioBuzz, we'll focus on how to manage a patient who visits the clinic complaining of chest pain. The primary goal in such an encounter is to diagnose the underlying cause of the chest pain. We need to know, is it coming from the heart or coming from a non-cardiac source? Importantly, we need to know whether it's due to coronary disease, angina, or not. Over the past years, our understanding of coronary artery disease has evolved significantly. We now recognize that coronary disease is not a single entity, but it's a complex condition that involves multiple syndromes. These syndromes share a common feature: transient reversible myocardial ischemia, a mismatch between myocardial blood flow and myocardial demand. And this could originate from the epicardial coronary issues or from the coronary microvascular tree. It could be due to structural or functional abnormalities of either epicardial coronaries or the small capillaries. Structural abnormalities include atherosclerosis, spontaneous coronary dissection, myocardial bridge, coronary aneurysm. Functional disorders, epicardial vasospasm, we used to know as Prinzmetal's angina, is due to autonomic dysregulation or endothelial dysfunction or hyperactivity of the vascular smooth muscles. Microvascular disease could also be structural or functional, could be due to intravascular plugging, perivascular fibrosis, extramural compression as in hypertrophic cardiomyopathy or hypertension or heart failure. It will also be due to functional abnormalities like impaired vasodilatation or increased vasoconstriction, secondary to autonomic dysregulation, endothelial dysfunction, and hyperactivity of the vascular smooth muscle cells. These structural or functional abnormalities can present in multiple forms. They could be totally asymptomatic, presenting only as abnormalities of functional testing. They can present as angina, where there is no occlusion of a major epicardial coronary. They could present as the classic angina with epicardial coronary stenosis. They can present after an acute coronary syndrome, after revascularization after bypass, and they can present in patients with LV dysfunction or heart failure. So in this episode, we'll delve into analyzing the chest pain through proper history, interpreting the symptoms in the context of the patient's atherosclerotic risk factors, performing the physical examination, and doing the initial tests during the visits, which could be an ECG, an echo, and blood tests. And we will dedicate a significant portion of the episode to discussing the choice of the imaging modality. We have various options like exercise tests, nuclear scans, CT scans, MRI, and we will learn how to select the most appropriate test based on the patient's symptoms and profile. Welcome to CardioBuzz.
Welcome to CardioBuzz, your one-stop shop for all things cardiology. We bring you the news, groundbreaking research, and the most recent guidelines. We interview the experts in the field and try to answer the most difficult questions of everyday practice.
So in the first visit, we'll take the history, do the physical examination, take the resting ECG, do the blood tests. We may do pulmonary function test or order an X-ray. If we're suspecting lung disease, we can have an echo at rest, maybe an exercise test. But by the end of that visit, we need to reach a conclusion about the clinical likelihood of having obstructive coronary artery disease. And we would end up in one of three situations. An emergency situation where the patient has clear unstable symptoms with heart failure, arrhythmia, then he needs to go to the emergency. On the other end, where there's a clear non-cardiac reason for the symptoms that we identified, and that we treat the underlying cause and reassure the patient. But in the majority of the cases, we need to do further tests to reach whether this is angina or not. So let's start by examining the chest pain. Chest pain is the most common symptom of coronary artery disease. Chest pain comes in different types, and the symptoms can vary depending on the age, the gender, race. Only about 10 to 25% of patients with coronary disease would present with the classic angina. The remaining 50 to 80% would have less characteristic symptoms. 10 to 15% may experience dyspnea rather than chest pain. That's why our understanding of the evaluation of angina has evolved. Traditional clinical classification of angina was typical, atypical, or non-angina, depending on the presence of three peculiar features that characterize the typical angina as we thought of it: constricting discomfort in the front of the chest, going to the neck to jaw, precipitated by physical exertion, relieved by rest and nitrates within 5 minutes. The atypical angina met 2 of these criteria, and non-anginal pain met only 1 of these criteria. And this was based on our understanding of the epidemiology of coronary artery disease in the 1960s and the 1970s. We knew that the nature of the pain, typical, atypical, or non-anginal, with gender and age, could predict the presence of significant obstructive coronary disease. That was the Diamond-Forrester matrix. For instance, a 30-year-old lady with non-anginal chest pain has a low chance of coronary artery disease, so further testing was unnecessary. On the other end, a 60-year-old male with typical angina had a very high probability of disease necessitating angiography, whereas a middle-aged male around 40 years of age with typical angina would have an intermediate probability of coronary disease and would have been referred for further testing, and exercise test was the most famous among them. However, this understanding is based on very old studies from the 1960s and the 70s and has changed. We started moving away from the word typical anginal or atypical anginal in 2021 with the ACC guidelines that clearly stated that chest pain should not be described as atypical because that term is not helpful in determining the cause and can be misinterpreted. And then they recommended at that time, instead of using typical or atypical, using cardiac, possible cardiac, or non-cardiac. There are features that increase the probability of the pain being of cardiac origin and others that make it unlikely to be of cardiac origin. We call it non-cardiac. But there are wide zones of overlap and many gray zones between cardiac, possible cardiac, and non-cardiac. And in the latest European Society of Cardiology guidelines published in 2024, we move towards a detailed description on the chest pain, with features increasing the likelihood of coronary disease like constricting, squeezing, pressure, retrosternal in the size of the fist, lasting 5 to 10 minutes, triggered by physical exertion or emotion, more frequent in cold weather, and subsiding within 1 to 5 minutes, rest or with some lingual nitrates. These increase the likelihood of coronary disease. Others would decrease the likelihood of coronary disease, like pleuritic chest pain, sharp chest pain on the right side of the chest, on a fine spot, lasting for several hours or days, triggered at rest or deep inspiration, or when pressing on the ribs of the sternum, relieved by antacids. These features, none of them is 100% conclusive that this pain is cardiac or non-cardiac. We also have dyspnea with features that increase the likelihood of coronary disease, like difficulty catching breath, occurring on effort, and rapidly subsiding after effort discontinuation, whereas other features decrease the chances of dyspnea being due to coronary disease, like wheezing, difficult to exhale, sighing, respiration, occurring at rest, associated with coughing, subsiding with the inhalation of bronchodilators. And instead of focusing only on symptoms, we need to consider the risk factors. So we combine the detailed analysis of the symptoms, and we need to counter 5 main risk factors for atherosclerotic disease: diabetes, hypertension, family history, smoking, dyslipidemia. We combine the nature of the symptoms and the number of risk factors, and then we reach a clinical likelihood of obstructive coronary disease that can be modified by the initial bedside tests like the ECG, the echo. Now that we have a more objective way of analyzing the pain, we can assign a score for each type of the pain. And the score ranges from 0 to 3. If the pain meets the 3 criteria: central compressing, on physical or emotional stress, relieved by rest or nitrates within 5 minutes, then it takes 3 points. 2 characteristics means 2 points. 1 or no characteristic means 1 point or 0 points. And we have similar criteria for dyspnea. Dyspnea that is described as trouble catching breath, that's aggravated by physical exertion, gets 2 points. If this feature is absent, then dyspnea gets 0 points. And after the symptom score, we count the number of the risk factors for coronary disease from 0 to 5. So let's take an example. A 50-year-old woman with 5 risk factors for coronary disease, and the symptoms are either 0 or 1. For instance, pain that's triggered by physical or emotional stress, that's only 1 point. The probability of this lady having significant coronary disease is very low, probably 5%. A 60-year-old man with 3 risk factors, diabetes, hypertension, dyslipidemia, and he gets 2 points because the pain is constricting, relieved by rest, then the probability of this man having significant coronary disease is only 70%. Third example is a 70-year-old male with 3 points of chest pain, the classic, and 5 risk factors, then he would be considered moderate risk. And then the natural question is, where are the high-risk patients? Why doesn't the risk factor weighted clinical assessment give us any high-risk patients? The answer lies the Diamond-Forrester classification. It's simply too old and outdated. Why is it outdated? Because number one, we have better models that align with the evolving epidemiology of coronary artery disease. And the most mature form is the risk factor weighted clinical likelihood model. This risk factor clinical likelihood model was adapted from a population of 40,000 patients Most of them were of Northern European origin, and then it was validated in another 15,000 patients against the gold standard of angiography and physiologic assessment. And why is the risk factor clinical likelihood score considered the best among them? Because it does not overestimate the probability of obstructive coronary disease like the Diamond-Forster classification or other models. So what happened? What changed? What led to the Diamond-Forster classification overestimating the probability of obstructive coronary artery disease? It's because there has been a change in the epidemiology of coronary artery disease. Because of the use of antihypertensive medications, statins, blood sugar control, and smoke control in the Western Hemisphere, there was a global decrease in the prevalence rates of coronary artery disease. This has been observed mostly in the Western Hemispheres, in the US, Western Europe, Eastern Europe, and Australia. But remind you that this was not observed in the Middle East or in Southeast Asia or in Sub-Saharan Africa. So the first adjustment of this risk factor clinical likelihood is in the geographic region. If you're seeing a patient in the Middle East, in Southeast Asia or Sub-Saharan Africa, then you can move them from a very low grade into a low grade, or from low grade into a moderate, or from moderate to high. The second adjustment to this risk factor weighted clinical likelihood is based on the ECG, the echo, and coronary CT score. So if we have ECG changes, or an exercise ECG with abnormal findings, or MV dysfunction, or arrhythmia, or peripheral arterial disease, or coronary calcification, then we can move patients from one risk category into the higher risk category, and from moderate risk into high risk or very high risk. The other adjustment comes when we have a severe elevation of one risk factor or comorbidity, a blood pressure more than 180, like familial hypercholesterolemia, like chronic kidney disease or peripheral arterial disease. Whenever we have one or more of these risk factors, then we move the patient from low to moderate, or moderate to high, or from high to very high category. And this reminds us of the importance of the physical examination, which has declined in the recent years. Performing a thorough examination, measuring the blood pressure, measuring the body mass index, listening for heart sounds, checking for arrhythmia, looking for other vascular diseases, thyroid disorders are of course very helpful and are not part of the past. ECG is of paramount importance. Repolarization abnormalities like ST depression or T-wave abnormalities increase the risk of the pain is of anginal origin. Pathological Q waves, conduction system abnormalities, atrial fibrillation, transient ischemia can all be detected via the ECG. And if the patient gets transient ST signal elevation with chest pain, then this is diagnostic of spastic angina. Ambulatory ECG monitoring, especially in women, can detect silent ischemia that does not correlate with physical exercise, but more with emotional stress. But it's important to note that ST depression during supraventricular tachyarrhythmia is not a strong predictor of obstructive coronary artery disease. Echocardiography is also important to assess LV function, presence of valvular disease, which could be the cause of angina, pulmonary hypertension, which could be the cause of angina, and of course this gets a class 1 recommendation in the guidelines. Initial laboratory tests, of course, include a lipid profile, a complete blood picture, serum creatinine with eGFR, fasting blood sugar or glycosylated hemoglobin, thyroid functions at least once are all essential. Troponin can be detected in some patients with stable coronary artery disease, and this is associated with adverse outcomes. Pro-BNP, of course, for suspected heart failure. We can also order high sensitivity C-reactive protein or for fibrinogen levels because they have prognostic implications, and there may be new therapies coming to target inflammatory markers or hypercoagulable states in chronic coronary artery disease. A simple test that we can also do to refine our risk assessment is the coronary artery calcium score. This test is simple, doesn't require contrast, and doesn't need slowing down heart rate excessively. It can give us insight to early atherosclerosis. We know that patients with very low or low clinical likelihood can be moved 1 or 2 grades in the risk assessment if they have elevated coronary calcium scores. So it's a useful, simple test that we can utilize more, and it can refine our initial clinical likelihood model. So to summarize the initial evaluation of patients with coronary disease, we look at the nature of their symptoms in an objective way, 0 to 3 points for angina, 0 to 2 points for dyspnea. Then we add to that the number of risk factors. We can reach a very low, moderate risk categories. Then the risk could be moved to a higher state based on the presence of ECG changes, echocardiographic changes, extreme elevation of one risk factor, or the presence of coronary artery calcification. Then we end up in one of 3 situations. A very low clinical likelihood of obstructive coronary disease, in which case we may defer further testing, or severe comorbidities and low quality of life. In these cases, there's no need for further testing, and these patients would be managed medically. The remaining question is produced in the low, intermediate, or high risk category. What should we do? What's the best imaging test for these patients? We have 5 tests: exercise ECG, CT coronary angiography, stress echo, nuclear testing, and cardiac MRI. Of course, the best test depends on your choice at the end of the day, considering the locally available resources, the access to these tests, and the patient's preferences. But we must remember that these non-invasive tests are all surrogates for the gold standard test, which is invasive angiography. And we wish we're able to do invasive angiography for anyone who presents with suspicious chest pain. But this is impossible because of the small risk associated with invasive angiography and, of course, the cost. So we still need to rely on these surrogate non-invasive tests in a big proportion of our patients. And keep in mind that these surrogate tests would give us a probability, an estimate of the presence and extent of coronary artery disease. And this probability is based on 2 factors: the prevalence of the disease, which is determined by the risk factor weighted clinical likelihood, and the peculiar features of the test itself. And there is usually a trade-off between sensitivity, specificity, positive predictive value, and negative predictive value in these tests. So in situations where the disease prevalence or the disease likelihood is low, we tend to go for tests that can give us some false positive results, like the coronary CT scan. But when the disease prevalence or the disease likelihood is on the higher side, then we go for functional tests because they can have some false negative results, and these false negatives will be reduced in the populations where the disease prevalence is high. Let's start with exercise test. Exercise test has been around for years. It's low cost, there's no radiation, it's widely accessible, it provides prognostic information. In patients who can exercise for more than 10 minutes without experiencing any chest pain or ST changes, they have a favorable prognosis and usually will not require further testing. While those patients with marked ischemia at low workload and high-risk Duke treadmill score benefit from further anatomical or functional testing. But the problems with exercise test is that it depends on physical fitness. You need a physically fit patient to go for the test. You need a patient with normal resting ECG without bundle branch block, paced rhythm, pre-excitation, ST depression at rest, or taking drugs. And the other issue is that if we compare exercise ECG versus CT scan or functional imaging, the strategy of exercise ECG will end up in more myocardial infarctions and more angina. This is because of the poor diagnostic accuracy of exercise ECG. The sensitivity of the exercise ECG is 58% and the specificity is 62%. And that means that there's a high likelihood of misclassifying almost half of the patients who go for the exercise test. Therefore, exercise testing in the modern era of cardiology has a very limited role. Only in those situations where we have limited access to coronary CT scan or functional imaging, or in patients with a low precast likelihood of obstructive coronary disease, where a negative test would now classify these patients into very low likelihood, and then further testing will be deferred. But you see, these are class 2B recommendations. They are very weak recommendations. The role of exercise test has markedly diminished. Coronary CT Angiography. This is a practical, non-invasive test with a very high diagnostic performance in detecting obstructive coronary disease. It gives anatomical data on the coronary course, grading the stenosis, the consistency of the plaques. It also gives functional data with FFRCT that does not require pharmacological stress, additional contrast, or radiation. And the recent studies did not show an increase in downstream invasive angiography after coronary CT scan. On the contrary, CT scan may reduce death and myocardial infarction when it's adopted as the first test. We know that from the Scott Hart trial that included more than 4,000 patients with stable chest pain, and they were randomized to coronary CT angiography or the standard of care. The strategy of coronary CT angiography resulted in 40% lower mortality and less non-fatal myocardial infarction. Therefore, CT scans are very useful in patients with chest pain who have a low or a moderate pretest likelihood of obstructive coronary artery disease. It can be used as the sole test, or it can be used as an add-on to functional tests to refine the diagnosis when the other tests are non-diagnostic. The problems with CT scan, of course, lies in patients with severe chronic kidney disease who cannot take contrast, extensive coronary calcification and the blooming artifact, severe obesity, fast and irregular heart rate, patients who are unable to cooperate and hold a breath. These conditions can make obtaining a good image quality unlikely, and so CT scan is not recommended in these patients. How about stress echocardiography? Stress echo has good diagnostic accuracy, allows risk stratification, it's relatively cheap, it's available on the bedside, can be easily repeated seated and has no radiation exposure, we can induce stress by exercise on a bicycle or with dobutamine and atropine. The problems with stress echo is that it's operator dependent and patient dependent, especially in obese patients where we have difficulty obtaining good images. Stress echo also relies on regional wall thickening, which may not occur if myocardial oxygen demand did not increase enough by the stress, or if the induced perfusion abnormalities are not large enough, as in mild coronary disease or in single vessel disease. Here, we may have an underestimation of the extent of ischemia. We see the same phenomenon in patients with microvascular disease. So the main limitation of stress echo is in the false negative results. We can reduce this false negative stress echo and improve the image quality by using contrast agents. These agents can enhance the image quality and allow us to assess the myocardial perfusion and the regional wall motion. Therefore, they improve the accuracy in detecting single vessel and microvascular disease, and these contrast agents are safe. Echo also allows us to take additional parameters like coronary flow reserve and lung congestion. These provide further insights into the coronary circulation, and they give us prognostic insights. And whereas CT scan is recommended in patients with low or moderate likelihood, stress echo is indicated in patients with moderate or high pretest likelihood of obstructive coronary disease. It's not recommended in patients with low pretest likelihood because our fear of the false negative results. Stress nuclear scans involve the administration of technetium-99 or thallium, which is taken by the myocardium, and the uptake of the tracer is dependent on the coronary blood flow. It creates images of the myocardium. If there is a hypoperfused area, there will be a drop in the myocardial signal. Stress can be induced by exercise on a treadmill or a bicycle, or with pharmacological agents like dipyridamole, adenosine, regadenoson, or dobutamine. These tests are widely available, generally have no contraindications. They provide prognostic information if we have large defects or increased lung uptake or stress-induced LV dysfunction. And the newer SPECT cameras reduce the radiation, shorten the acquisition time, and improve the accuracy. The problems with nuclear scans that they require a normally perfused myocardial reference. So this could be challenging in patients with multi-vessel coronary disease, tending to give us some false negative results. And of course, we have some diaphragmatic attenuation that can disturb the interpretation of the test. So similar to stress echo, nuclear scans are useful in patients with moderate or high pretest likelihood of obstructive coronary artery disease. The most updated scanners, the PET-CT myocardial perfusion scanner. This utilizes short-lived tracers like ammonia, rubidium, or water. It's conducted at rest or with pharmacological stress with a non-contrast CT scan, so it can give the coronary a calcium score, high-quality images with low radiation exposure, and they have superior diagnostic performance over other functional imaging methods. And they have a unique strength of measuring myocardial blood flow at rest and during the hyperemia, giving us the myocardial blood flow reserve. Low myocardial blood flow reserve predicts mortality and identifies patients likely to benefit from early revascularization. The limitations of PET-CT are the limited availability, the high cost, and challenges in combining it with physical exercise, which is more physiological. Again, they are useful in patients with moderate or high pretest likelihood of coronary disease, especially if they are obese, young, suspected multivessel disease, or microvascular dysfunction. Cardiac MRI has the advantage of providing a comprehensive assessment of cardiac function. It gives the volumes, the cardiac function, can measure myocardial blood flow, and can give us a general idea about the coronary vessels. There are no ionizing radiations. We can also use dobutamine for stress. However, the problem with MRI lies in the high cost, the limited availability, and the need for long time in the scanner, especially if the patients have claustrophobia. Non-MRI safe pacemakers, ICD, and gadolinium is risky in patients with renal failure. Similar to nuclear scan, it's recommended in patients with moderate or high pretest likelihood of coronary artery disease if we need to assess cardiac function and tissue characterization. So to recap, anatomical imaging by CT is preferable in low or moderate pretest likelihood of coronary disease, whereas functional imaging by stress echo, nuclear or cardiac MRI preferable in patients with moderate or high pretest likelihood of coronary disease because of the false negative rates, so we keep them for the moderate or the high risk. They give us information on viability and microvascular disease, we don't get them by coronary CT scan. And if we detect abnormalities by CT scan or by functional imaging, the next step is probably referring them for an invasive angiography. But there will be some situations where we detect abnormalities in anatomical imaging and we need to add functional imaging, or vice versa. For instance, patients with heart failure, where we need to combine the coronary anatomy with a viability assessment, or patients after revascularization with bypass, or patients with severe coronary calcification where CT scan cannot give a true estimate of the lesion severity. So let's take some examples here. Let's have a 70-year-old woman with 4 coronary risk factors and exertional dyspnea. Symptoms give her 2 points and she has 4 risk factors, so the pretest likelihood is 16% in the moderate range. If this patient gets a CT scan, remember CT scan is recommended in low or moderate. If this patient gets a CT scan that is negative, then the chances of having coronary artery disease are very low and we can stop at this stage. And let's have this example that will show us the importance of combining anatomical and functional imaging. Let's assume we have a 55-year-old man, 2 coronary risk factors, and all 3 anginal chest pain characteristics. Based on the risk factor weighted model, his pretest likelihood of coronary disease is intermediate, 27%. Negative coronary CT scan would mean that the post-test likelihood is less than 10%, and we can stop testing at this stage. But if the CT scan is abnormal, then the post-test likelihood moves from 27% to 40%. Why is that? Because CT scan can overestimate the lesion severity. So maybe alone it's not enough. Then if we start by a post-test likelihood of 40% and we do a stress echo, if the stress echo is positive, then the post-test likelihood moves from 40% to 80%, and then we can proceed to angiography. And let's take this example, a 69-year-old man with 4 coronary risk factors and all 3 anginal symptom characteristics. That gives him a pretest likelihood of 45%, but the risk was moved to the higher category because of resting ECG abnormalities and peripheral arterial disease. In this man, an abnormal stress echo would increase the likelihood of coronary disease from 60% to more than 90%, whereas a negative stress echo puts it only in back to the intermediate risk category. So then we need another test like the CT scan. If it is negative, then the chances of coronary artery disease are less than 10% and we can continue just with medical treatment. And then you may answer, why don't we just go for invasive angiography? And I agree with that, but as I told you, there will be some situations where you need to combine anatomical data with functional data before you proceed to invasive angiography. Invasive angiography is recommended in patients with a very high clinical likelihood of obstructive coronary disease. From the start, we go directly to invasive angiography. We can also go to invasive angiography if we have high-risk findings in coronary CT scan, like left main or proximal LAD or two-vessel disease, or any stress echo that shows moderate to severe inducible ischemia with high-risk features like more than 1 segment, stress-induced NV dysfunction, or a Duke Trendle score less than 10. Of course, angiography is not free of risk, and the decision to perform invasive angiography should balance the benefits and the risks. There should be a process of shared clinical decision making, and patients should be adequately informed of these aspects ahead of the procedure. And of course, whenever we have intermediate lesions or lesions of doubtful significance, we need to do a physiologic assessment with an IFR or an FFR with a pullback, because if the disease is diffuse, then medical treatment is probably sufficient, whereas in patients with a focal disease, then revascularization could offer a better alternative. So to recap, we combine the symptom score with the number of the risk factors. We reach a clinical likelihood of obstructive coronary disease that is modified by the ECG, by echo, by individual risk factors, or by calcium score. Then for very low risk, we defer further testing. For low probability, we go for CT scan, maybe exercise ECG. For moderate probability, we go for CT scan or functional imaging. For high probability, we do go for functional imaging to assess viability and the extent of ischemia, whereas in very high risk, we go for invasive coronary angiography. So by the end of these tests, we will reach the conclusion on the presence and extent of obstructive coronary artery disease, and the next step is to decide on what's the best medical treatment, or do we need to send for revascularization or not, and these will be discussed in the next episode.
Thank you for watching this episode. Please write in the comments and tell us, what do you think of the risk factor clinical model, and which test do you prefer to diagnose coronary artery disease? If you like the content, hit the thumbs up button, subscribe to the channel, and click on the bell to activate the notifications. Feel free to spread the video among your colleagues and share it in your networks. See you soon!